Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, today we're going to deconstruct the pharmacology of histamine and antihistamines. Our goal here is to build a solid framework, a mental model that will help you master this for your exams and for clinical practice. So here's our game plan. We're going to start with the molecule itself, histamine. Then we'll look at the receptors it acts on and the chaos it can cause. After that, we'll get into the drugs that fight back, the different generations of antihistamines, how they work, when to use them, and what to watch out for. And we'll finish up by highlighting the absolute must-know high-yield points.
Okay, let's dive in. First things first, we have to understand the molecule we're trying to control. You can't really get how the drugs work until you get what histamine is all about. So histamine is what we call an amine autocoid. Now, that term autocoid might sound a little intimidating, but all it really means is local hormone. Think of it this way. A typical hormone, like thyroid hormone, gets dumped into the bloodstream and travels all over the body. Histamine doesn't do that. It acts right where it's made, causing trouble in its immediate neighborhood.
And its name gives you a huge clue. Histamine literally means tissue amine. Why? Because it is absolutely packed into our tissues. It's synthesized and stored inside mast cells and basophils, which you can think of as the body's little landlines, strategically placed right at the front lines, in your skin, your lungs, and your gut.
What's really interesting here is how simple it is to create such a potent molecule. It's a one-step reaction. You take the amino acid histidine, an enzyme comes along and snips off a carboxyl group, and boom, you have histamine. It's then stored in these tiny granules, ready to be released the moment it gets the signal. Okay, so we know what it is and where it comes from. Now, let's talk about what it actually does. The key to understanding histamine's effects is to understand its receptors. The same molecule can do wildly different things depending on which receptor it binds to in a given tissue.
This table lays it all out beautifully. Let's focus on the big two. First, the H1 receptor. This is your classic allergy receptor. When histamine hits H1, you get bronchoconstriction, making it hard to breathe. Your blood vessels dilate and become leaky, causing swelling and hives, and it stimulates nerve endings, which causes that intense pain and itching. Then you have the H2 receptor. Totally different job. This one is famous for being in the stomach, where it tells your gastric glands to pump out acid. And then there's H3, which is mainly in the brain, acting as a brake, telling neurons to stop releasing histamine. So, to put it all together, these actions are the direct cause of the symptoms we see. That swelling and redness from a bug bite, that's H1 causing vasodilation and leaky capillaries. The wheezing in an asthma attack, H1-mediated bronchoconstriction. This direct line from receptor to symptom is the entire basis for antihistamine therapy.
All right, now that we understand the problem, let's talk about the solution. We're moving on to the H1 antagonists, the drugs most people just call antihistamines. Now, this is maybe the most important concept for this whole class. H1 antagonists are split into two major groups, the older first-generation agents and the newer second-generation agents. For exams, the prototype drug you absolutely have to know for the first generation is diphenhydramine. If you understand how diphenhydramine works, both its benefits and its problems, you understand the whole class. This chart is pure gold for exams. The single most important difference between these two generations comes down to one thing: can it get into the brain? First-generation drugs are lipophilic, or fat-loving. This means they can easily cross the blood-brain barrier, and once they're in the brain, they cause that famous sedation. Second-generation drugs were specifically engineered to be less lipophilic, and they get actively pumped out of the brain, which is why they're non-sedating.
So let's see how these properties play out in the real world. We'll look at when we actually use these drugs and, just as importantly, what we need to watch out for.
The pharmacokinetics, the journey of the drug through the body, is pretty standard. They're absorbed well when you take them by mouth, they're processed in the liver and cleared by the kidneys. But again, the most critical step is distribution. I'm going to keep repeating this because it's the whole story. Whether or not that drug gets into the central nervous system determines its side effect profile and many of its uses. And that brings us to their therapeutic uses, which go way beyond just allergies. Look at this list: motion sickness, vertigo, sedative for sleep. What do these have in common? They're all brain effects. And that's why these jobs are exclusively for the first-generation agents, the only ones that can actually get into the brain to do the work. This diagram is absolutely critical.
It explains why first-generation drugs are so famous for their side effects. It's because they're not very specific. They're designed to block the H1 receptor, but they're kind of messy, so they end up blocking a bunch of other receptors too, like muscarinic and alpha-adrenergic receptors. Think of it as a dirty drug. It hits off-target sites, and each of those hits causes a different side effect. When these drugs block muscarinic receptors, for example, you get that classic set of anticholinergic side effects. You may have heard the mnemonic: can't see, can't pee, can't spit, can't poop. Dry mouth, blurred vision, urinary retention, constipation. This is a really big deal, especially in elderly patients, where these effects can be much more severe. Okay, let's briefly switch gears to another important class of histamine blockers. These are the H2 antagonists, and they target a completely different receptor for a completely different purpose.
So, unlike the H1 blockers for allergies, the H2 blockers, like cimetidine and ranitidine, are all about the stomach. They are workhorses for treating acid-related problems like peptic ulcers and GERD. Their mechanism is incredibly specific. They block H2 receptors on the parietal cells in the stomach lining, which is a key step for telling those cells to secrete acid. All right, let's bring it all home. We're going to distill everything we've talked about down to the most important, high-yield takeaways for your exams and your clinical rotations. Here it is in a nutshell. The choice between a first-gen and a second-gen antihistamine is almost always a trade-off between side effects and specific uses. If you need to treat motion sickness, or if you actually want that sedative effect to help someone sleep, you have to use a first-generation drug. But for someone who needs to get through their workday without feeling drowsy, the second-gen agent is the obvious and much safer choice. This is a classic exam question, so commit this to memory. You'll be asked to connect the side effects of a drug like diphenhydramine to the specific receptor it's blocking. So remember, sedation is from H1 blockade in the brain. Dry mouth and urinary retention are from muscarinic blockade. And that feeling of dizziness or lightheadedness can be from alpha-adrenergic blockade. Knowing those links is crucial. And to wrap this all up, let's end with a clinical scenario. You have an elderly patient who has both glaucoma and problems with urinary retention. They come to you with terrible seasonal allergies. Which generation of H1 antagonist is the safer choice here, and why? Think back to those anticholinergic effects we discussed. Working through a column like this is what really solidifies these concepts and prepares you for practice.